Good afternoon, everyone. It's Peter Braden here. I am the Senior Executive Director of Policy for Health in Department of Health and Human Services. And I'm really delighted to have been invited today to MC this webinar of the Victorian COVID-19 Cancer Network. Before getting started, I will just acknowledge that wherever we're streaming into from today, we're all on Aboriginal land, and I'll pay our respect to Elders past, present and emerging. And also to all the Aboriginal staff making a contribution in our various organisations. So look, you're all aware of the network, but it's really been set up to help respond to the challenges of delivering cancer care in the context of this global health crisis, the COVID-19 pandemic. As the slide says, it's a joint initiative between the Victorian Comprehensive Cancer Centre and Monash Partners. And it's there to provide information and support and communication for clinicians and health services who are delivering cancer care. If people are streaming in and haven't become a member, you can join now at the website of either the VCCC or the MPCCC. So I'll just make some really brief remarks because we've got a great lineup of presenters and panelists to talk through some really fascinating stuff today. But I just did want to acknowledge that it's a very difficult time for all of us. The impact of the public health measures in terms of physical distancing and lockdown, that there's loss of life in the community, there's morbidity, and there's real challenges managing and delivering services in these circumstances with furloughed staff, a lot of uncertainty, and dealing with a pathogen and its consequences that we still don't, of course, fully understand. But while it's a really difficult time, I think it's also quite an inspiring time. So I'm responsible for working on policy in health, and we're seeing really amazing innovation and really bold strides, making progress that would have been pretty unimaginable just a few months ago. There's lots of examples I won't go into. I'm sure we'll hear about many of them today, but massive structural transition to telehealth that really would have been unthinkable previously. Cooperation across organisations in a really dynamic way that's quite new in our fragmented health system. And of course, a lot of what's going on in cancer and indeed the establishment and the work of this network. So it's a challenging time, but it's a really exciting time. And I think that it's one thing that me and my team are really looking at is, what can we hold on to? What can we further extend and sustain out of all of these changes in the way care is being delivered? To continue to gain the benefits of all that innovation and change. So that's why it's great for me to be able to MC and participate in, answer questions, but more importantly, hear what you're doing, so I can learn from it and think about how we can support it and sustain it. So thanks to Grant for the invitation, and I will let you know before getting on to the rest of the program how you can participate. So there's 3 ways you can do the Q&A. It's illustrated there on the slide. You can raise a virtual hand. If you raise a real hand, no one will know. And you can use the chat function to ask questions of panelists and to make comments as we go along. So really look forward to hearing your questions and what you've got to contribute through those 3 mechanisms. I will hand over to Grant, who will manage the panel and the session with them. I think you're probably all very familiar with Grant McArthur, and if I was to do a comprehensive biography, I'd use up too much time. Suffice to say, he's the Executive Director of the VCCC. He's the Chair of Melanoma and Skin Cancers at the University of Melbourne, Head of Molecular Oncology Laboratory, and also Senior Medical Oncologist Consultant at Peter Mac. So thank you for inviting me to do some introductions, Grant, and I'll pass to you to, or I might introduce the rest of the panel to give Grant a bit less work to do. So along with Grant, we'll be hearing from Dr. Robert Blum, the Clinical Director at Bendigo Health Oncology Unit and Loddon Mallee Integrated Cancer Services. And we'll also be hearing from 3 co-chairs of the network, Associate Professor Sue-Ann McLaughlin, Medical Director of Oncology and Cancer Services at St Vincent's, Adjunct Clinical Professor Andrew Hayden, Joint Clinical Director, Southern Melbourne Integrated Cancer Services, and Medical Oncologist at Alfred, and finally, Adjunct Clinical Professor Ziwan Wong, Joint Clinical Director at SMICS and Head of Oncology at Peninsula Health. So quite a high-powered group, and looking forward to hearing what you've got to say. Thanks, Grant.
Thanks very much, Peter, and great pleasure to host this webinar today, and to have Peter as chair. As Peter outlined, there's actually a lot of really exciting opportunities that come out of the challenge that we're finding ourselves in at the moment. So we've titled this webinar, Where to From Here? I'll give you a brief introduction at a high level to some of the opportunities and the things we're going through, some information on the Victorian COVID-19 Cancer Network, and then we're going to really have a deep dive into some specific issues using the brain power of our co-chairs and today, and we're going to address hopefully a lot of issues that are very topical and of interest for you. But please do participate in the discussion by putting up your questions on chat in the Q&A, and then when we get to the question time at the end, you can also raise your virtual hand. Okay, so what are the challenges and the opportunities the pandemic brings? If I could have the next slide, thanks. So I think it was one of our former prime ministers that, at least in Australian context, coined the term of "don't waste a crisis." And interestingly, across the Victorian COVID-19 Cancer Network, this particular phrase has been used quite a bit. So what do we really mean by that, though, in the context that we're finding ourselves in at the moment in the cancer sector? Well, we all know that we have extraordinary pressures on the health system. We see totally new ways of having to deliver care to our patients. New workflows have had to be developed. There's a lot of prioritisation that's had to gone on. And whilst you're going through all this, there's really great opportunities for learning as you go. And I think each of us that work in the healthcare sector, and for most of us on this call, the cancer sector, can really focus on some of these learnings as we go. It's very, very important to, of course, think about the patients with cancer during this time. It's an incredibly difficult time. And in the network, on our task force, we have consumer leaders which have been really instrumental in feeding in the patient perspective at the moment at this difficult time. Not only that, as I'll get to, the network has brought together a number of key organisations involved in cancer control in the state. That has included the Cancer Council Victoria, and who, of course, as I think everyone knows, has a patient support line. And so we're getting data and input from the patients directly through the Cancer Council support line about the things that are important to patients. So, what really is summarised on this slide for you is that we've got an opportunity to come together, if we could go back, please. Thank you, Cynthia. Like never before, through collaborations. Yeah, we're just going forward rather than back. Thank you very much. So there's an opportunity for institutions, for organisations to come together like never before, to really therefore learn as we go, to think about the cancer system as a learning health system in the middle of this crisis, so that we can do things differently in the future as we come out with it. So summarised on this slide, and I really want to acknowledge just what a great partnership the approach here has been. The network was established by the Monash Partners Comprehensive Cancer Consortium and the Victorian Comprehensive Cancer Centre. However, integral to the work that we're doing is the Integrated Cancer Services, who have generously reprioritised their work to assist the network and our health services around the state. Cancer Council, as we'll get to, have been able to provide fantastic data through the Victorian Cancer Registry that has helped quantify and look forward to what the problems the cancer sector are going to face. And I've already mentioned the tremendous input through the patient support service at Cancer Council Victoria. And behind all of this, the Victorian state government have been very engaging, very open as we face the challenges in the cancer sector at what is an incredibly difficult time for the whole community, for government and for the Department of Health and Human Services. If I could have the next slide, thanks. So the network that's been established at the moment, in this digital workspace, we have over 500 members. Regular newsletter is distributed to over 700 members, and in total 150 organisations represented. So this is really connecting the cancer sector in a way that has never occurred before. If I could have the next slide, thanks. So the network is indeed multidisciplinary. So if you look at the data here, on the left, you can see that oncologists and nurses are the two largest disciplines involved in the network. However, it really does extend, across many disciplines that are so critical in cancer care, and this is, I think, one of the strengths of the network. Not only that, but there's representation from regional Victoria, and indeed colleagues from interstate, are joining in the network as well. And although Victoria, as we all know, are carrying the brunt at the moment, unfortunately there could be a situation where what's occurring in Victoria occurs in other states. And so, just in the last week, I know colleagues from New South Wales have been very engaged at reaching out to people involved in our network to understand the way we're doing things that might support the New South Wales cancer sector as well. If I could have the next slide, please. So what we'll be doing today is to have a discussion, dive into some significant questions, which I will moderate together with the other panel members. And if we could go to the next slide, please. Peter's introduced our panel, but Rob Blum, Sue-Ann McLaughlin, Andrew Hayden and Ziwen Wong will form the panel, and I'll have some of these questions that we'll get the panel to respond to. Please, whilst we're talking, you contribute as well through the Q&A, the chat, or put your virtual hand up in question time. So with that introduction, let's go across to the panel and get our panel up, and then we'll start off with our first question. Thanks very much, Cynthia. Okay, so thanks panel members for joining us. And look, Peter mentioned in his introduction that there are a lot of new initiatives that have had to occur during the COVID-19 crisis, and I think a bigger change than the use of Ziwen Wong chairs the telehealth group within the Cancer COVID-19 Network. And so I might kick off with the first question to Ziwen. What do we really require to ensure that telehealth remains an integral part of clinical service delivery going forward?
Thanks, Grant. I think there's a lot to answer that question completely. As Peter has alluded to, with the pandemic, it has really catalyzed the uptake of telehealth across all of the healthcare sector, not just cancer. And the uptake of telehealth has been 100%. I might actually share my slides, which I did prepare a couple, if I may. So that's just very quick summary, and hopefully I'll be able to answer your question with the slides. with some of the information in the slides. I just wanted to quickly summarize what are some of the work that the telehealth working group within the network has been up to. So we came together very quickly at the end of March and early April when the network was formed. And we wanted to be sure that there were enough representation from across the sector, not just clinicians, cancer clinicians representing both metro and regional services, but also consumers. And also we wanted to make sure that there's representation from the Department of Health. So we also had Department of Health representation on the working group. On top of that, I also had someone from Cancer Council Victoria. So we put our heads together and very quickly in first week of April, did a very quick survey across all the cancer service providers in the state on the uptake of telehealth. And what we do see, as you can see on the screen, 100% of all the cancer services have taken up telehealth in a very, very short period of time. And we will know that telehealth has been rolled out across the state in some health services, but not everyone. And the uptake has not been, I believe, as quickly as it was intended to be, particularly from some of the barriers, which I will talk about very shortly. And we also asked the health services what form of telehealth platforms they're using. And about a quarter to 1/3 of them are only using phone. And the rest of them are using video platforms such as Health Direct, which is what is supported by the Department of Health. And the remainder, a variety of different platforms from FaceTime, Zoom, Doxy.me, and others. And so what was really important, and to answer your question, Grant, was what are some of the barriers and what needs to occur in order to implement telehealth. And this is a really good opportunity to go in and see what are some of the challenges. And not surprisingly, about half of the health services cite the lack of infrastructure as one of the predominant challenges. And this includes, the computers which are telehealth enabled, such as the provision of cameras and speakers within the ambulatory services. Patient education, telehealth literacy is another main contributing barrier, and the lack of support in terms of administrative and IT within the individual health service as well. So these are the three top barriers, and what we've done very quickly is put together a letter to Medical Journal Australia as a letter to the editor to cite some of these challenges in the hope to try and lobby support to address some of them very quickly. And they have been, and we're very grateful for that. The other question in our survey was what were the enablers to implement telehealth in the institution? And not surprisingly, it is the mirror image of what was the barriers. So what was interesting is following some of this work, we actually had within the network, we're able to have direct conversations through various working groups, as well as directly with the Department of Health and also with the cancer expert reference groups to indicate that infrastructure support really needs to occur. And I'm grateful that, the department has actually responded very quickly with commitment to infrastructure support for health services. And more recently, we've got the Victorian Integrated Cancer Services addressing that in their member health services. What the government has done was to enable telehealth to occur more broadly than the conventional MBS telehealth item criteria within a very short period of time. And certainly there's been a lot of lobbying effort to try and make sure that this extends beyond the current end date of 30th of September for specialists. For GPs, it has been extended from 20th of July in patients who have a pre-existing relationship with the practice. And we certainly see effort, not just from us, but also from other organizations such as Cancer Council Australia, Cancer Council Victoria, COSA, AMA, and the Royal Colleges have all lobbied, have all surveyed their members and have written and spoken to decision makers regarding the same. So I put together some of the thoughts from feedback from our own group as well for consideration. What are some of the opportunities looking ahead for telehealth? I think it's changed the way we manage patients with cancer forever, I would say. And I think the ideal model we feel would be a hybrid of face-to-face and telehealth. In certain instances whereby patients who may require, bad news to be broken to them and their family may require to be seen face-to-face. In other circumstances where physical examination needs to be conducted in directly with the patient, then those would have to occur. And in others, I would say majority, up to 3/4 of the patients who have cancer can actually be seen via telehealth quite effectively, in particularly video. And we can then broaden that to a shared care program between regional and metro providers, with GPs in programs such as survivorship care beyond the active treatment phase. Our group and others have also put together guidelines in scenarios or situations where cancer can be cancer care can be conducted very effectively through telehealth. And I won't expand on, but I think there are others that need to look into is the expansion of teletrials across the state, leveraging on the ability of doing telehealth and the use of telemonitoring in other instances such as hospital and the home and others. What's really important with some of the services which are still struggling with their capability would be to map what the current infrastructure, IT and admin limitations would be. And certainly the ownership is on the health services with support from the department. But as I said earlier, integrated cancer services have come in as of early this week to speak to the member health services and work out how we can have a semblance of what may be a telehealth coordinator on the ground to facilitate the occurrence of these video consults going forward. What was important to realize, and still is the equity of access, the issue of telehealth literacy amongst our patients, particularly in those who are more vulnerable, the elderly, patients who are in the Aboriginal Torres Strait Islands, and who are belonging to the culturally and linguistically diverse group. How do we reach out to them to make sure they do have the equipment, they are aware, or they have a support person with them? And how do we make sure that the mode of delivery of cancer care is a joint decision between the patient and the clinician, the health service, so that we can empower them to be involved in that decision making. And as we conduct more and more telehealth consultation, I think the quality of telehealth needs to be looked at. And certainly there are lots of consumer surveys out there which have been conducted within the individual ICSs. And also there's multi-site surveys that the Children's have pioneering, and our group and others are looking at not just consumer surveys, but also clinician survey. And perhaps in the future, the findings from all these surveys could be developed into some form of an audit or toolkit that can then monitor quality of the telehealth consultation going forward. And as you conduct more and more telehealth consults, the communication skills, it's pivotal for not just the clinician, but also how the consumers can help to enhance the experience with telehealth. And finally, I'd like to say that, in this last couple of months, it's been amazing, the shared learning between different specialties, not just medical oncology, cancer care, but also across specialties such as nurses, allied health. And particularly, I think the allied health team have been very advanced in implementing telehealth. And there's also a lot of shared learning between our partners and the cancer community in interstates, such as in Queensland, where they've done telehealth for more than a decade and a half. And a lot of interactions with them to share what the experience is and what we can learn from their very rich experience. And certainly across countries to different states and different countries, we all also learn what they have done and what we can learn from them. I'd just like to end by saying that telehealth is here to stay. And I think the onus is on us and everyone who's involved, from decision makers to clinicians to allied health community and patients and everyone else to make it work and work well. And I think it's going to be a constant ongoing process, not something that we do now and then it's going to require constant fine tuning. I hope that answers part of your question, Grant.
Absolutely. So I've got another couple of questions to ask of the panel on the issue of telehealth, and I'm going to ask a challenging one first. So we've heard feedback from patient groups of the inadequacies of telephone versions of telehealth without involving video. And, I think nationally the data is that 90% of telehealth consults are on the telephone during COVID-19. So you put those two things together and I think you could argue we have a problem. So a question really for the whole group: how do we overcome that? If indeed overuse of telephone consultations as a version of telehealth is a problem, how do we overcome that? What are the major barriers to get people off the telephone and onto the video? Rob.
So I think from our experience, we've actually had pretty good uptake of telehealth, and it's pretty clear to me that you need the infrastructure you need the setup, you need the education before you have your first consultation. You need to have the administrative support, and you also need the buy-in from the clinicians. We even found when we did our survey that within the same department, the uptake or percentage of telehealth was very dependent on the clinician. So what I've also found personally is that once an individual has negotiated a telehealth the first time and got over some of the difficulties, the subsequent ones are usually actually okay. So it's just getting over that initial bump. That's, I think, really important. So it really does require preparation. It's like most things. If a person has a good experience the first time, they're likely to be happy to do it a second time. If they have a bad experience the first time, that's when you run into problems. So I think it's about that preparation, but you definitely need significant administration support. And we've even got staff members that go into the virtual waiting room, and actually when they can see someone's been waiting there for just letting them know that the doctor's running a bit late. So you need that system.
Yep. And Andrew.
I just want to echo what Rob has said. I think it is so important that the clinicians strongly encourage the patients to use the video health to begin with, because and what I've experienced is that if it doesn't work, then the patients say, look, I'll just give me a call. I'll use my phone. They know how to use that, and they'll revert back to that. And so it's crucial, up front that you can get the video health working. And if it doesn't, you've got to keep trying to get them to have a good experience with it, because I think once they've had a good experience with it, they'll be happy to continue doing it.
So Anne.
We've got a large group of patients who are non-English speaking background, and I guess all of us have patients who are in the older age groups. And I think for these people, it's particularly challenging. I agree that video is far superior than the telephone. So I think certainly in our centre, we're going to be trying to add resource in terms of a patient coordinator, a telehealth coordinator, to actually sit down on the telephone and coach someone through if they're having difficulties. And I think we need that kind of level of input to get some disadvantaged groups over that hump, as Rob spoke about. I think once people have got over the hump of doing one, then I think we'll be right. But I think we need extra resource to really get more people onto the video platform. I think that'll be important.
Yeah, that's a great point. And I remember early in the when the network was established that that there was some real innovation in Western Victoria of delivering smartphones and iPads to the local Aboriginal and Torres Strait Islander community who were without the technology, and people would go and deliver the devices so that they could partake in telehealth. Okay, great. So look, I think we might move on. I think we heard some furious agreement there from our panel about the need for putting resources into education and training for both patients and staff. So I'd now like to move on to one of the other interesting learnings that might be sustainable going forward about networks and clinical networks and advocacy. So we heard from Z1 about advocacy around telehealth, but question, and I might get Sue-Ann to respond first, is how have these clinical networks worked together during this COVID-19 crisis? And, and thinking going forward, how important are they going to be to help, supporting our clinical workforce in a sustainable way once things start to settle with COVID infections?
Yeah, so at the end of March or early April, we were all very uncertain, and the network allowed people to come together very quickly. We had to act very quickly, and we soon realised that by working together, we could achieve more. And I think that was it was fantastic how that worked out. And there's a number of groups that have pulled together within the network, tumour stream groups, clinical groups, advocacy, consumer advocacy groups. The one that I've been involved with particularly is the clinical directors group. So this is unprecedented. I think we all the clinical directors of oncology units or cancer units around Victoria all know each other and get on well, but we don't have a lot of interaction apart from going to conferences and things where we can impact. But very quickly, the clinical directors group came together and we've been meeting 1 to 2 weekly since the end of March. So clinical directors from regional centres, metro centres all come together via a Zoom conference every week. We bring our issues and our challenges to the group, and we've achieved a lot, I think, in the time that we've worked. We've had much better connections between metro and regional. We've understood the challenges that our regional colleagues have. We've worked together with them. Some of the examples of what we've been able to do, early on it became apparent that the Symptom Urgent Review Clinic, which is operational across some centres in Victoria, some cancer centres, that's a nurse-led clinic available for patients to discuss side effects of their treatment, get advice about how to manage their symptoms, education. Became apparent that this particular service would be pivotal during the COVID time. And we had quick discussions with the Department of Health around this, and we were very well supported by the Department of Health. Extra resources were made available to extend the ones that were in existence and bring on new services in centres that didn't have them. And speaking from my own centre, it's been an incredible service, and I think something that we won't go back from. It's allowed us to see patients in their homes via telehealth, avoid emergency visits, self-management of symptoms, questions around COVID risk. It's really been, a fantastic service that I think will probably be extended from here. So that's one of the things that was achieved very quickly, and we were very well supported by the Department of Health on that one. Department of Health made available a toolkit around home chemotherapy programs, which had been in development for some months, but they made that toolkit available to us very quickly because, again, people found or thought that delivering chemotherapy at home during this period would be an advantage. Interesting findings from that. We did a survey of the clinical services around Victoria about their home chemotherapy programs. Only about a quarter of the services had programs that were fully functional and able to take on extra capacity during this time. So that was an incredibly important learning and really illustrated that work needs to be done in that area. And going forward, I think that work will get done and will be important for the future. So these are sorts of things that we're able to achieve very quickly. And then we've started to look at some initiatives between metro and rural services. So partnerships working together to make services and specialised services available to people in regional centres through really well thought out partnerships. So these are sorts of the things that we're still working on, I think will be important for the future.
Right. So from here in Melbourne's Botanic Gardens, I might turn to Rob Blum and get Rob to follow on with Sue-Ann's last comment about regional metropolitan networks. And any learnings do you think, Rob, that we've seen about the way that regional centres and metropolitan centres can cooperate and work together during this time?
Yeah, I mean, I sort of echo what Sue had to say. I think what's probably happened historically is that a lot of the relationships have been based on personal or personalities and their connections beforehand. But I think what we're now starting to think is a little bit more in a coordinated fashion, because again, most of the regional centres will then have their own subsequent smaller centres that they will provide care with. So I think thinking about it more holistically is really important. And I know that in terms of the networks, when COVID was initially being planned for, we also set up weekly meetings or networks with all of our sub areas to make sure that people were working and doing things in a uniform sort of a way. And that was particularly important when we were having to plan potentially if we had to rationalise treatments because of staffing that might have been affected by the conditions. So I think some of the things may have happened in the past somewhat haphazardly, or maybe whereas I think the concept of networks and doing things in a systematised way has been heightened, and also that concept of making sure that things are being done in a uniform way, and having to also be able to have a system that you can switch on really quickly if you've got to suddenly change your tact, I think has been absolutely critical. And I think the power of having all the directors in the one room, you can't over articulate how important that's been, because you need to have a time protected and space for thinking and for sharing in a way that's regular, rather than the more pleasant but haphazard discussions you have at a conference.
Yeah, so I think that's one of the key, learnings out of this current crisis, is the value of that clinical leadership network across the clinical directors, which has been repeatedly said needs to continue in perpetuity. I'd now like to turn the discussion to how data can inform our strategy in cancer. We've been so fortunate to have, comprehensive and very current and up-to-date cancer data from Victorian Cancer Registry during this time. Why has that been helpful, and how has it influenced the task force and its actions? And I might get Andrew Hayden, who's been very involved in taking some of these key data into senior levels of government, to comment on that. So how useful, Andrew, has having access to this really up-to-date data been, do you think?
Thanks, Grant. It's been crucial, I think. So we've been very fortunate that in Victoria we have access to almost real-time registry data with regards to cancer notifications. And the team there have been able to supply us regularly with updated reports from the registry. And what we have seen has been a very clear, marked and sustained drop in cancer notifications since the first wave of COVID hit Australia. This reduction in cancer diagnoses has been in the order of about 30%. It has varied a little bit depending on which tumour stream you look at, but it has been fairly consistent across the board. And so, although we may have had a gut feel that there was less new cases coming to our clinics or less patients presenting for workup of cancer, it's crucial to actually be able to have the real data to support what we were feeling and what we were sensing. And so this reduction in cancer diagnoses has led us to be able to make a number of conclusions, which have then led to interventions. So we estimate that over a 6-month period, if there's a 30% reduction in cancer cases, we're looking at about 3,000 Victorians that are having a delayed diagnosis of cancer. And the implications for this are immense, in the sense that this delayed diagnosis is likely to lead to stage migration, which is likely to lead to poorer outcomes with regards to survivals, as well as implications with regards to the workforce, with patients presenting with more advanced disease, it's likely that they're going to need more complex treatments, and from our point of view, very substantially increase the likelihood that they will need systemic therapy, either as adjuvant or palliative treatments. And so with this data, we're able to then escalate this through to government and to get some very clear messages out that are important with regards to making sure that patients are told to continue to seek advice, see their general practitioners, present for investigations if they're unwell, if they're symptomatic. And we've been able to make sure that there's ways that the messages can be sent through to the CEOs of the hospitals as well, to try and make sure that cancer is not affected by any reduction in elective procedures. I think one of the things that's important that has come out of the VCCN is that we now have really a direct link with regards to government and being able to escalate our concerns through meetings that we have with Safer Care Victoria, that then can raise issues that can be escalated up the chain to really affect policy. So without the data, none of this would have happened. It's crucial.
And going forward, the ability of perhaps getting a broader range of data too related to cancer, other than the new cancer notifications, would be incredibly powerful, might be another really key opportunity coming out of the COVID situation. Now, I'm a little mindful of time, and there's a lot of questions coming through that Peter Braden will moderate for us. So, look, I think we might just tackle one more question now, and then let's interact with the audience and the great questions that they're putting through. So, one conversation that's happening around the whole healthcare sector is, is there some learnings here about lower value treatments, and that given the need that we've had to prioritise treatments. So for cancer, is there modifications that have occurred to systemic therapies in the current climates that there are learnings from going forward? And I'll just put that out to the whole panel for whoever would like to comment on that one. So Anne.
You're on mute.
So far, across most of the health services, oncology particularly, I think it's safe to say that we haven't had to interrupt people's treatment at this point in time, although we're carefully watching that because the situation is changing by the day, really. But it has made, I think, us think very carefully and hard about risk-benefit ratios, or risk-benefit, particularly in patients with metastatic incurable disease, when we're thinking about third and fourth line treatments for some cancers that we treat. Thinking at this stage, well, certainly so far it's been on an individual patient basis, I believe, but, and it's real, we're sitting down with people saying, well, this is the situation, these are the risks that you face at the moment. There's COVID, there's side effects of treatment, there's complications, ending up in hospital, and trying to balance that against benefits, which may be very modest. So I think it's really called into question, and it's made us think very hard about that each time we treat a patient. So at the moment, I think it's individual patient based. We haven't had to look at scaling back on treatments in a broad sense, but I think it's made us think hard about that in the current context.
Okay, and look, there's maybe just before opening up to questions with Peter, just one more thing, if we could comment on that's come through as a question, is clinical trials. So what learnings in research and clinical trials do we think, that we're going to be able to take out of the current situation as learnings going forward? Andrew, perhaps you've had some interesting experiences with teletrials, for example.
Yeah, before I talk about teletrials, I think that one of the things that is important for us to continue to try and push is for remote monitoring for patients on clinical trials. That will certainly ease the workload, and it will help everybody, not just the patients and the researchers, but also the people that are gathering all the data and the monitors. And so, you know, that's something that I feel very strongly would be really important to try and could be a huge positive coming out of COVID. The other thing, obviously, is teletrials, and you know, there aren't a lot of positives from COVID, but I think that teletrials could in fact be a real bonus. And it's amazing how the pandemic has actually allowed what was looking like taking months or years of red tape and bureaucracy to get teletrials up and running, has been able to allow us to kind of really speed up the whole process. You know, it has really shown us what is capable when we put our heads together and really want to make something happen. So this came about because we had a couple of patients who were on clinical trials at our centre that were actually living in Tasmania and actually coming up to Melbourne every 3 weeks for their treatment, but then because of lockdown were unable to continue their treatment. And so literally, you know, within a number of weeks, with a lot of support from the Tasmanian government and also from the governance and ethics departments at both hospitals, we were able to open up teletrials, you know, across state borders, which, yeah, you know, if you'd asked me 6 months ago, is that something that we could realistically get up and running this year, I would have said no, I don't think so. So, you know, I suppose it comes back to what you were saying at the start, Grant, that, you know, never miss out on the opportunity to benefit from a crisis, and perhaps that is something that we can really take out of this as a positive.
Excellent, thanks. Look, I might hand back to Peter now to moderate the questions that have come in from the audience. Thanks so much for some terrific questions that I see have come through. Over to you, Peter. Thank you.
Great, thanks Grant, and thanks panel for a really fascinating discussion. So questions have been coming in. Please keep pinging us in the Q&A function or in the chat. One theme that's come through in a few questions is really about telehealth and equity, be it about hearing difficulties, language, technological literacy and age, etc. I just wonder if anyone wants to comment on the panel on what good approaches have been done to engage consumers in the design or through consultation or through other means, made sure that telehealth is not introducing new and different equity issues in access and quality of care. Does anyone like to comment on that? Ziwan?
Peter, I might just comment on that. So I think there's been a lot of initiative by different organizations to try and bring education and health literacy to the consumers. Certainly I know Cancer Council is very involved, and they do have a very busy hotline where they sort of answer patients' queries. But there are proactive education programs out there to try and educate the public what telehealth looks like through videos and online social media and different things. I think for those patients who have hearing difficulty, what some of us have tried to do is to see if there is a family member or a relative or friend who may be with the patient and is able to actually be the supported person during the telehealth consultation that we can set up a video with. And we are actually sometimes surprised that they feel more comfortable in the safety of their home rather than to be in the clinic, and the consultation actually goes better. And I think the other situation will be when you need an interpreter, and certainly with the video platform, it's possible to do an interpreter, but I also believe that there's been work that's done to actually optimize that process. So it's work in progress, really.
Great, thanks, Siwan. And I know that Safer Care Victoria is looking at this and a lot of other aspects of telehealth and how to avoid potentially low value and what are the workforce capabilities needed to do it well. But those equity issues are obviously really important. There's a question that's come through relating to, Andrew, the points you raised, the alarming statistics about reduced diagnoses and notifications. I wonder if anyone on the panel would like to comment on to the question what we think the drivers are there about that, but also importantly what we think are the responses and mitigations we should do to reverse that trend and to catch up. Do you like to comment about that, Andrew?
Yes, so look, I think that the drivers of the reduction are multifactorial, but mainly around a drop in patients kind of seeing their primary healthcare professionals, interacting with their GPs and seeking advice and reviews and investigations of symptoms when they arrive. That's certainly part of the problem. And then there's also been a drop in screening. So we know that breast screening stopped for a couple of months earlier in the year. There's been a clear drop in the number of patients presenting for gastroscopies and colonoscopies. And so there's been, a drop in screening, and I think that there's probably been a decrease in the number of patients that are having cancers found incidentally when they are investigated for other symptoms. So people are not having as many investigations such as CT scans or other blood tests that might have picked up abnormalities that led on to further investigations and a diagnosis. It's not just one thing. I think it's many things. And I think that the real most critical and important thing that we do is to try and continue to get the message out to patients, not to ignore symptoms, not to be afraid to go to see their GPs or present to the hospitals when they need to be investigated. And we're also working with the GPs really to try and encourage them to equally, continue to send their patients off for investigations and refer their patients on if they feel they need him.
Great, thanks. Maybe I think Grant, you wanted to speak, and then Robert.
Yeah, thanks. Yeah, thanks, Peter. Look, the mitigations that I think have been, successful through having a network is trying to bring to the, public's attention, the community's attention, the need for early presentation. So there's a Don't Delay campaign, Cancer Council Victoria about to launch. Cancer Australia and Cancer Council Australia are also looking at campaigns, and we've had a Safe Cancer Care campaign as well for patients not to delay, their investigations when they've already had a diagnosis of cancer, that we've run through social media through the network jointly with the Cancer Council Victoria. So these are all really important, and I think going forward, when one thinks about it, these are all great initiatives that we should look to continue on, beyond COVID.
Great, thank you very much, Robert.
Oh, just one quick comment, and it was a discussion that was had with the advisory group. What I don't really understand, and I don't know what the data is, but I think the point about that first consultation with their primary healthcare giver or GP is really critical. And what I don't really know is, what is the stumbling block? Is it just about the fear of COVID, or is there something about those interactions that have now changed that make it less accessible to people? And I think we need to be talking to the patients about that information, because that will impact how we address the problem.
Thanks very much. Clearly that issue of patient engagement and co-design is a bit of a theme coming through, as well as that important link to primary care. But there's a question that's come through about remote monitoring, and when and how can we stand up remote monitoring at scale, and maybe for which cohorts, or with what kind of focus? Does anyone want to talk about the opportunities for remote monitoring? I mean, from my point of view, I know we're trialing some interesting applications for COVID positive patients in the community, but for cancer, where do you see the opportunities in remote monitoring specifically? Siwan?
Yeah, Peter, I might just start off by saying that I think part of what we thought could occur and may already be occurring in some areas are patients receiving treatment at home could be monitored as well. And some of the patients who may be discharged earlier from the hospital may be monitored at home rather than having been in the hospital for an extended period of time. And other examples, for example, in the COVID ward, I am aware that some of the health services have set up sort of virtual ward round whereby so that they try and minimize footprints within the COVID positive wards, for example, so that there are additional opinions from clinicians without necessarily having the clinician physically being there. I'm sure others would know about the examples too.
Great. Any other thoughts on that?
Peter, I might just add that, you know, really interestingly in the Parkville precinct, 3 a.m. tomorrow morning, the new electronic health record will go live. And it's been fascinating that, you know, initially there were a lot of concerns about implementing a brand new electronic health record during the COVID crisis, but, you know, getting to the point Z1 just made about remote monitoring, I'm really looking forward to being able to do a ward round from home as of 3 a.m. tomorrow morning. I think these sort of innovations in electronic, you know, health records and health systems, you know, are going to be very, very beneficial going forward.
Thanks very much. One from me, in the context of telehealth, you know, to a lesser degree, maybe virtual care or remote monitoring, what are the opportunities you see for secondary consultation, team-based care, the sort of, I guess we've talked about, you know, direct delivery of care that we already do through a different platform, but do you see any opportunities to change the way that happens across the healthcare system through, you know, forms of better integration or information sharing, etc., like to change the actual model of care as well as just how it's delivered? Robert?
I think for me, one of the key issues particularly with regards to research is the fact that regional people are often disadvantaged because of their geography. And I think that it has been raised, but if there was an opportunity for people to actually receive their treatment where they live with their unit under the auspices of the principal team running the clinical trials, you would increase your participation probably through all institutions. And I think that this is an opportunity to actually bring that to the forefront. I think that it's possible. It's about the red tape and about the infrastructure to support that. But I think that this is something that would be really important to carry forward, and it would increase the rates probably for everybody, but particularly for regional and rural patients, which is probably half of what occurs in metropolitan Melbourne. So I think that's a really critical aspect.
Thanks, Robert. Sue-Ann.
Yeah, just on another example of metro-regional partnerships. So the multidisciplinary meetings that we have across cancer for tumour streams are now suddenly have become video conferencing, which during the pandemic, which actually works extremely well. So we now have a platform, and we're looking into this to partner with our regional colleagues so that they can dial into the multidisciplinary meetings and present their patients at different tumour streams and have access to all of the opinions and that we all have when we're discussing cases. So the imaging can be transferred electronically. We can see the histopathology on the platform. So it's like you're all sitting in the same room, but the doctors from regional Victoria can have their cases discussed by a big team of people. And then we're trying to extend that to actually have some telehealth appointments so that the city clinicians, the highly specialised city clinicians, can see the patients via telehealth. If there's a need for special investigations, they can be brought down, but they can have their consultation via telehealth platform. So I think these are new things that have been kick-started by the pandemic. It's something we probably should have got onto a long time ago, but we're onto it now and we're developing these new initiatives.
That's great. Look,
Done before.
yeah, it's exciting. Look, we are at time, so what I might do is I'll just do some wrap-up comments, but then we might just run over by just 5 minutes to do 1 or 2 more questions if panelists can stay, and or the audience can stay if you want to drop off. Of course, many of us have other meetings, but I do want to sort of thank the network for setting this up. And we got a lot of great questions we haven't been able to answer, but if people join the network, there are lots of opportunities to share and answer those questions through other forms. A little tiny answer from me regarding a question that came in about psychosocial support. There's been a big investment in a lot of specialised web platforms, services and phone lines expansion for COVID type psychosocial support. So I'm happy to get that information circulated to attendees afterwards just to answer that question directly. But yes, look, thank you very much to the panelists and to everyone for attending. Been a really great discussion. We'll continue 1 or 2 questions afterwards for those who can stay. I'd also like to thank Cynthia and Erin for doing the producing behind the scenes and making it all run smoothly. So thanks for that. And for those who have to drop off, thanks for joining. For those who can stay for 1 or 2 more minutes, just because we've got such a great group of people together, I noticed one of the other threads coming through the questions was really about research. How are we sharing the results? What are the opportunities for research? It's a pretty open question, but what are people seeing as to use the topic of today, the where to from here for cancer research and how that'll change in the new environment? Great.
Yeah, I might kick off with that. Look, I think research will be different going forward. You know, Rob touched on the fact that more regional patients could access research, not just an interventional clinical trial, but involvement in other research studies as well remotely, because we've had to learn to do that. So I think that's a major opportunity. You know, I have seen in the discovery research space some incredible productivity coming out of computational biologists and bioinformaticians at this time, you know, where, you know, people have been emphasising that type of research. So that might have a real enduring impact on the way that we understand complex data. And the disease of cancer is a bunch of diseases that are very, very complex and need those powerful computational tools to understand. So I think that that will be quite different going forward. But there was that question that I love that came up about, there was a question about should we be sharing, you know, and to prevent duplication, some of the studies that are going on. And it really got me thinking, this is a great suggestion because, you know, one of the wonderful initiatives has been clinical trial registration of projects such that, you know, you can really see so quickly now in you know, what clinical trials are happening, you know, all across the world. And yeah, why not? Why shouldn't we be doing that with COVID, you know, related research or other areas of research as well? A research registry to link people that might pool their efforts together in research projects to answer questions more quickly rather than duplicate. So yeah, great question that came through. I really like that one.
That's great. Thanks very much. You know, so we are 5% over time, and I know everyone's very busy, but before wrapping up, we'll just ask if anyone on the panel has any final comments they want to make before we close. Sue-Ann?
There were some questions, I think, about clinical trials, which we didn't really touch on too much. And I guess that's been tricky. We thought that initially we thought we were going to have to close things down, and there were some initial moves to do that. And then as things in Victoria seemed to be on the low side, we started opening things up and getting things going again. And now we're in the position where we're needing to think about clinical trial activity in our health services, and it's complex. It's often about staff resources available. We've got furloughed staff and people needing to be working from home. So the clinical trial space is pretty challenging. We're trying to keep open as much as we can, but thinking about clinical trials where the treatments have a high risk of complications and side effects, thinking about if people are needing to come into hospital and putting them at risk. Those sort of trials have been, some of them have been suspended for now, but other studies that are more straightforward and pose less risk, a lot of those studies are continuing across health services. So it's a moving feast, and sorry, I've got background noise here, but we're watching it all the time and trying to make things as available as safely in that space.
Thanks, Peter. And I might just say one comment in winding up too, and that is, you know, just a heartfelt thanks to the whole cancer community for coming together the way they have. You know, to the Integrated Cancer Services, Cancer Council Victoria, patient groups, other advocacy groups, government, clinicians, you know, everyone has come together in a remarkable way. And, you know, let's keep it going, because I think it provides opportunities to really get the very best care for everyone with cancer throughout the state. So thanks, everyone.
That's great. Thank you so much, Fran. Great words, and look forward to all the work on these themes we've heard about today.